Hello, my name is Austin Mahajan, and I'm a first-year osteopathic medical student at the Ohio University Heritage College of Osteopathic Medicine. Today I'll be presenting a unique case, the first documented report of synchronous mucinous neoplasms of the appendix and the pancreas. Besides being the first documented, this case is important for coordinated care. This is because mucinous neoplasms have malignant potential, making early diagnosis critical. If left undiagnosed, they can spread to the peritoneum, significantly affecting survival. To better understand this case, let's review what we know about these tumors. Appendiceal mucinous neoplasms, or AMNs, are rare, accounting for 0.4% to 1% of all GI malignancies. They're slightly more common in females and frequently present with non-specific symptoms, leading to delayed diagnosis. Over 50% of cases already have peritoneal involvement at diagnosis, increasing the risk of pseudomyxoma peritonei. Management depends on tumor characteristics. Appendectomy is sufficient for localized disease, while right hemicolectomy is recommended for tumors greater than 2 centimeters, high grade, or invading the muscularis propria. Mucinous cystic pancreatic neoplasms, or MCPNs, are almost exclusively found in women, with a 20-to-1 predominance, suggesting a hormonal influence. These tumors are found in the body or tail of the pancreas in 93% of cases, and typically present in isolated cystic lesions, with a median size of 5 centimeters. MCPNs are asymptomatic until late stage, which leads to delayed diagnosis. Notably, they are strongly associated with estrogen and progesterone receptors, reinforcing the hypothesis that hormonal factors play a role in their pathogenesis. With this background, we're ready to discuss the clinical case. A 51-year-old postmenopausal female on progesterone and bioidentical hormone replacement therapy presented with non-specific abdominal discomfort and unexplained weight gain. Initial imaging identified a 2.4 centimeter pancreatic cyst with nodularity, prompting referral to gastroenterology. MRI confirmed these findings, and repeat imaging was scheduled in 3 to 6 months. Due to her age, a screen colonoscopy was recommended, but she deferred that for another 6 months. At follow-up, colonoscopy and CT imaging revealed critical findings, leading to surgical intervention. Now let's take a look at these findings. Colonoscopy revealed an inverted appendix protruding into the cecal lumen, the so-called volcano site. It was also firm upon compression with forceps. This raised concern for a possible mucinous neoplasm. Follow-up CT findings showed pancreatic cyst enlargement, which had grown from 2.4 centimeters to 4.2 centimeters, as seen in image A. A dilated appendix measuring 1.4 centimeters without signs of acute appendicitis was also noted, as seen in image B. The decision was made to proceed with a distal pancreatectomy and appendectomy to prevent possible malignant transformation. Following surgical resection, pathology confirmed 2 distinct neoplasms. The first was a mucinous cystic pancreatic neoplasm, which was negative for high-grade dysplasia or carcinoma. As seen in image A, histological examination revealed columnar cell lining with dense ovarian-like stroma, a defining feature of MCPNs. Image B shows a low-grade appendiceal mucinous neoplasm. It was confined to the muscularis propria, with no peritoneal spread. Since both neoplasms were detected early, curative surgical resection was achieved, preventing malignancy transformation. Now let's review the clinical takeaways from this case. First, pancreatic cysts with nodularity should prompt GI referral, as they may represent pre-malignant or malignant lesions. Even when small, follow-up imaging is essential to monitor for continued growth. Second, the volcano sign, an inverted appendix firm on compression during endoscopy, should raise suspicion for LAMN. Recognizing this sign early can guide further workup and avoid delayed diagnosis. Third, the role of hormone therapy in mucinous neoplasms should be carefully considered. Estrogen and progesterone may contribute to tumor growth, but further research is needed to determine how these hormonal factors play a role in the progression of these tumors. Given that this patient was receiving bioidentical hormone therapy, it raises significant questions about whether hormones played a role in the progression and development of these synchronous tumors. Finally, early diagnosis is critical. Delays increase the risk of peritoneal spread, significantly worsening prognosis. By recognizing these features, clinicians can improve early detection and optimize management strategies. I hope you found this case interesting and understand the importance of early recognition of GI neoplasms. Thank you for your time, and here are my references.